Okay, I'm going to talk on the pathology quality journey and show why accreditation really does matter. It's a story, and it's a story that you're part of. It's important to understand how we got here. So this diagram is the Australian Pathology Quality Framework. It took me years to understand how it all worked, and nearly as long to draw this diagram. So I did this diagram. The college made it pretty for me. There are lots of components, lots of organisations, lots of history, and I'll be going into this later. So Andy and I are a pathology accreditation duet, and I'm going up to 1986. So this is where I cut my teeth in quality, at Southern IML Lab in Wollongong. I moved there as CEO in 2000, took over from Steve Anderson, who founded the practice. It was the first pathology lab in Australia to be ISO 9000 certified before 15189. Steve and the lab were leaders in the quality movement and embraced TQM, so it was my education. That's a young me, terrible haircut and terrible tie, and Steve Anderson. The actual building was originally the Burleigh Bra factory, so the saying was quality or bust. So, Ranjini Raja, I don't know if she's in the audience, is now, good on you Ranjini, is now the laboratory manager there and flies the quality flag still at Southern. There's a new lab, they've got a new lab. I don't have to convince you, but pathology is at the heart of our present healthcare system. As we know, everything starts and ends with a patient. The need for accurate and timely results drives quality. Bad quality pathology gives bad outcomes. Wrong, unnecessary treatments, unnecessary follow-up testing, wasted resources. So most current Australian labs have good quality management systems and cover the whole organisation. They ensure quality by accrediting against a standard, and they continuously improve. All aspects of laboratory operation are risk managed. Our quality is good because we have our national quality framework and accreditation. Congratulations to all those involved in quality, and many of you are here. But it wasn't always like this. So I'm going to take you on a little history tour. So from ancient civilisations to the 16th century, all pathology came from learning about disease from post-mortem findings, initially funerary procedures, and later curious scientists like us. This is the first pathology test. It was in Egypt, 1500 BC, when urine that attracted ants was used to diagnose diabetes. So I put a little note here. I'm sure QAP, not sure QAP could develop a proficiency test for this, but they'd give it a go. I know they'd give it a go. So there weren't virtually any more pathology tests done for over 3,000 years, other than perhaps using Eye of Newt or something. And then things really changed in the Enlightenment. 17th, 18th century, facts and reasons were used to understand the universe. The previous 1,000 years, virtually, there was little advancement in science. Microscope was a huge breakthrough. Zacharias Janssen, Dutch spectacle maker, is credited with inventing the microscope in 1590. Prior to that, if you can imagine, no one could see less than the width of a hair, and when the microscope was invented, suddenly there was this new world appeared right under our nose. So the 19th century was a great century for the advancement of pathology and science and medicine in general. Pasteur, Lister, Koch, Blundell, Ehrlich, Virchow, Bence-Jones, and lots of others. Amazing period of history for science and medicine. Some of them are still household names. So the 19th century pathology discoveries ushered mankind into the 20th century with pathology for all. So widespread access to pathology, despite the hundreds of years of scientific discoveries only really happened 120 years ago. So pathology departments only started to form in the mid to late 1800s in universities and hospitals. Up to that time, the autopsy was the only thing you could have, which wasn't really useful in life. Australia was similar to the rest of the world, and Sydney Uni had a lab in the late 1800s, and Melbourne Uni was soon after that. And so it was pathology for the people arrived. And it's not that long ago. It's depending how old you are, your great-grandparents or your grandparents. First time pathology was available. So Prince Alfred and Sydney Uni by 1902 ran departments that were linked. By this time, hospital tests had been introduced for TB, cholera, typhoid and diphtheria. And by the 1920s, they also had testing for blood glucose, urine, haemoglobin, blood transfusions, microcultures and AP. But routine testing was very limited to this small group of tests. So I found this list of pathology tests from an American lab in 1914. I couldn't find anything of Australian labs, but I imagine the Australian list is similar. It's a short list. This is all you could get, and some of them, I don't even know what some of them actually are. But so it was very limited, and that's our roots, not only 100 years ago, really. So I have a little view into early 20th century laboratories, as my mother was a pathology scientist in the 1940s, and she worked for this trailblazing early pathologist called Eva Shipton. Eva was one of the earliest women to become a senior doctor in Australia and was a foundation fellow of the college. In the 1940s and 60s, she ran a private pathology practice in Macquarie Street, Sydney. So my mother, May Bott, worked for Eva as a scientist from 46 to 48. So Eva and one of the pathologists, two of them, Eva and someone else, would go out and collect all the specimens themselves, including all the bloods, bring them back to the small lab. My mother did all the chemistry and haematology, and her colleague, Elaine Murray, did all the AP and micro. Two scientists, two pathologists, all test tubes, all manual. Pathologists did all the microscope work. In fact, they did everything with the help of the scientists. This was the biggest private laboratory in Sydney. This is the pre-runner of DHM or somewhere of or Laverty's or something. Yeah, amazing. So the college wrote an article on my mother, Elaine, and Eva Shipton in 2006. That's my mother in her 80s. And sorry, here we are, I'm up to date. My mother in her 80s, her graduation photo, and Elaine Murray is still alive, 99 years old, so she's going well. In later years, I just wrote down, Eva used to hit malfunctioning automated equipment with a walking stick, I'm told, which is a good story. So I tell this to give some perspective on the time. Hospital labs in the 1950s were probably a bit bigger, but probably not that much bigger. In the 1950s, there was concern about reliability of test results. So pathologists that's starting to want to improve their quality. Problems were caused by technical and ethical issues because there were no standards, so people had cut corners. So not long after this period, they also had the introduction of all the automated equipment, all the auto-analyzers, so the volume went up. And in the early clinical pathology laboratories, the established academic methods showed significant variability and could not give reliable results. They all knew this, so they were looking at ways to reduce this variability. And they found the answer in industry, particularly manufacturing. So now my potted history of quality, and I'll go quickly. So quality, it's a good cartoon, isn't it? Quality was always important for personal needs and good for business. Standards have been around a long time for weights and measures. In pre-medieval times, quality was based on an individual commitment, but in medieval times, the guilds developed. So there was the concept, a minimum standard of output, training and inspection. Blacksmith guilds or the Bakers Guild or you name it, they were big. During the Industrial Revolution, there was still limited focus on processes, but all on the output. So earliest 20th century was the big breakthrough in industry, and there was increased focus on monitoring of processes by statisticians and inspection of the output. In the US, as we know, are big leaders with this. It's been mentioned before, the World Wars really advanced quality as the bullets from one factory had to go on the guns of another, and they wanted to blow up the enemy, not themselves. Post-World War II, there was a focus on the whole organisation and the quality of the processes. And the new Japanese factories welcomed the input of Americans, Duran and Deming. The new approach became known as total quality management. And that actually wasn't mentioned in documentation until 1980. So they had the sort of concept there, but not the name till then. TQM was about creating standards, checking performance against the standards and continuous improvement, Kaizen. Very, very familiar, obviously, to all of us. So statistical quality control was used in industry from 1900. The control chart was invented by Walter Shewart in 1924 for Bell Laboratories to improve the reliability of telephone lines. Sorry, thank you. So Edward Deming became an admirer of Shewart's work and became his advocate. And so that's how he became a very significantly famous person in the World War II industrial growth. So the quality processes used by industry, particularly manufacturing, suited pathology. Again, drawing on industry, pathology labs realised the standardisation of methods was required, including referencing to a gold standard, calibration. So while pathology labs found similarities to industry, they also knew there were differences. We have patients. So in 1952, they started to adapt some of these things, and one of the first ones was the Stanley Levy and Elmer Jennings adapted Shewart's control chart in chemical pathology to become the Levy-Jennings chart. That was in 1952. So 1960s, 1980s, previously noted, there was this rapid development in automated analysers in haematology, clin chem, with a consequent large increase in test volumes and a big need for better quality. This is when patient results started to be used for quality control. So the swinging 60s gave us the Beatles, auto-analysers, and markedly improved quality control. And forgive me, but perhaps yesterday or my quality seems so far away. Sorry. It's potentially a dull talk, all the history, so I had to, anyway. Maybe it's true. But this guy is a rock star of quality control, James Westgard. Landmark for quality was his development of the Westgard rules in 1981. But I've jumped ahead, really. So if we go back now, and I'll give you a little bit of history of the college. So in 1956, the college was established by an enthusiastic group of pathologists led by visionary first president, Edgar Thompson. I did a rehearsal with my wife and she pointed out to me, she said, well, he doesn't look very enthusiastic. It's true, isn't this picture? I'm sure he had a very nice smile, but anyway, so... Anyway, the college started because pathologists wanted a local organisation that could undertake training and education, was a voice for pathologists, and could create standards of practice. One of the earliest activities of the college was establishing quality standards. They understood both the diagnostic needs and they were well aware at the time of the progressing quality movement. So the college's focus on quality was both for technical and ethical reasons, I mentioned before. They saw it as their responsibility. Significant levels of lobbying of government took place between the 50s and the 70s. It's a lot of lobbying to get support for government and to improve the quality of pathology practice. In 1957, a document was sent by the second president, John Perry here, to fellows to formulate and get approval for a set of standards. So this 1957 was the first step to where we are today. In 1960, the International Society of Pathology raised the issue of undertaking surveys of the performance of laboratories to ensure laboratory standards. The college acted quickly on this, and in 1961, Peter Hendry, who later became president, began conducting proficiency surveys in clinical chemistry. It was given further impetus when an observant orthopaedic surgeon at Newcastle noted an excessive number of gout diagnoses because of the aberrant uric acid tests. That's what the feedback was coming from the clinicians, that there's something potentially wrong there. So this photo, this is Peter Hendry. There's no photos of these eminent people, and so anyway, this is on the president's wall of photos and was right up the top. And it's at a weird angle because I had to get somebody hop up in the reception desk on one leg and take the photo. And I googled the photo and I found Peter in his 90s. I thought it was a microscope, but it's a walking stick. And he lived to 102. He only died in 2017. So, interesting. QAP. So, the college starts proficiency surveys in 61, and by 68, there was a program for everything. They eventually formed a company and separate from the college in 1988, 100% owned by the college, and is now a large supplier of EQA programs, both nationally and internationally. Some of you are probably here, I'm sure, are in this audience. So in 71, the college brings out a report which suggests setting up an accreditation board under government to maintain and improve the standards of all routine pathological investigations, and thus, 1, protect the patient by ensuring reliable pathology results and assisting with proper interpretation. 2, to ensure that the public, the government and the health funds get the best available results at the most economic cost. Well, how good a statement's that? You know, really impressive statement, and that's the direction they took off into. So the college then sent delegations down to Canberra to seek assistance from government to create a national accreditation scheme. The college's initiatives were helped by the Hospital and Health Services Commission in 1972. Initial deputations were disappointed by government, but the college persisted, and eventually in 1975, government supported the initiative and a joint pathology working party was set up. Within 3 months, the concept of having a National Pathology Accreditation Advisory Council, NPAC, was agreed. It then took 4 years for this idea to become reality, and NPAC was gazetted on February the 20th, 1979. Interestingly, I was going through the dates myself, it was the Whitlam Labor government that agreed to it, and it was the Fraser coalition government that actually gazetted it and brought it in. So it had widespread political support, and why wouldn't it? So we come to the RCPA NATA partnership. So with the regulatory framework in place, an accreditation scheme had to be created. It was realised that it would be unacceptable for pathologists and scientists to monitor themselves, so they looked for a partner. Dr. Lou Davies and Dr. David Rothfield suggested approaching NATA, which was an organisation, as we've heard before at this conference, that was formed in 1947 by government to supply an inspection and accreditation service for analytical laboratories. So it was like perfect. It was just a great fit. Sorry, I got out of kilter again, but I think you got the story. So it was just a great fit, and NATA took the opportunity. So negotiations between NATA and the college began in 1981, and a scheme of voluntary participation based on NPAC standard was agreed in 1983. So NATA established a medical testing division, we all know this, and it was tied to Medicare in 1986. So it was voluntary to then, but once you tie it to Medicare, it applies to all countries. Everybody does it. So this year's the 40th anniversary of the first NATA Accreditation visit in 1984, which was the San Hospital, Wahroonga in Sydney. I'm still there. The lab is still there. So just to comment on peer assessment, I think we have something special. The college and NATA has really formed a great partnership and delivered top-level accreditation over the last 40 years. The powerful aspect of the accreditation scheme is the peer assessment. Through the partnership, working pathologists and scientists, as I say it, with practical knowledge, accompany the lead assessors and give the program the depth and the skill that it really needs. There's advisory committees making sure everything stays contemporary. It's a very, very well designed scheme from the start. The mutual benefit of the scheme for all the labs is clear, and the support from all the labs is in terms of volunteers is amazing. As a past college president, I always find the time people give to these things, the volunteer time and even the organisation's time, is just amazing. So, big congratulations for all people involved. It's a widely acclaimed program worldwide, one of the earliest in the world, if not the earliest, and very successful. I also wanted to make note that there are other important organisations involved. Certainly fellows were, the college were big contributors to 15189. The TGA is another significant organisation that's got involved in setting standards and ensuring compliance. As well, APRA, all training organisations for pathologists, scientists, AMC, ISO, all play important roles. So we're back to my diagram, which took a long time putting together, and it has been appreciated through the college because there are 4 pillars: training, standards, accreditation and proficiency testing. Quality needs many things: good standards, effective accreditation against the standards, proficiency testing, quality training of both pathologists and scientists and others, a supportive regulatory environment, and adequate funding for public and private. You can't do this stuff without good funding of pathology. And if I've left any organisation out, particularly if they're in the audience, I apologise, because there are other organisations I know from this meeting that are contributing. If everyone wants this diagram, the college has got it. I'm sure they would share it if you want it for your talks or something. So much of what's on this diagram really came from that lobbying of the 50s to the 1980s, and to their credit, the understanding, support and funding by government. So it took a while to get going with government. They got it in the end, and they supported it and have put in great institutions to support the quality framework of pathology. So last slide. Our pathology ancestors knew that accreditation matters and fought for it, knowing that a patient was at the end of it. The Australian accreditation system, with all its contributing organisations, maintains the high quality of pathology that we enjoy and contributes to the best possible health outcomes for patients. Incorrect results in Australian pathology laboratories are rare, thanks to the accreditation system which commenced with the RCPA NATA partnership in 1983, based on AMPAC standards. it would not be possible to run the modern, operationally complex laboratories that we now have without good accreditation. So thank you for listening.
So let's go back though to the reason we have an accreditation program, and that's because there were concerns with federal government and RCPA about the quality of pathology testing in Australia. So out of those concerns, the accreditation program was founded, and that's really important today as well. So I think if we look at the original objectives of the program, to improve the standards of pathology, is what we've talked about. There were concerns about the standards, recognise those meeting minimal acceptable standards, and recognising accreditation is just that. It's not best practice, it's only labs meeting minimal standards, no more than that. Encourage debate and discussion on appropriate standards, heighten awareness of the need of appropriate education and training, progressively raise standards of pathology practice and clinical consultation, which is still what we do now. When we get new tests in, we tend to start at a lower level. As we do more assessments, the practice gets better as we do more assessments. And the bottom one is why NATA exists. I think that's why we all work for NATA, is to protect the public when we actually find a poorly performing lab. So NATA does do follow-up assessments. We do suspend accreditations when we find poorly performing labs. As I said, that's why all of us, that's why I've been here for 17 years, is because we are actually doing something to protect the public. So I'm going to now go through some milestones from 1986 up to the present day, and then peer a little bit into the future to see where we may be heading with pathology and how accreditation needs to sort of keep relevant to how pathology is going to move on. So, as Lawrie said, 1986 was a key date, was when it was linked to Medicare. I think we had a handful of accreditations until that date, and then all of a sudden everyone was very interested in getting accredited in 1986. We had hundreds of applications almost overnight. And most labs made it through those standards, but there were a small but significant number of labs who didn't make it through. They couldn't meet the minimal requirements, they didn't get accredited, and therefore did not have access to Medicare funding. Oh, sorry, I've just been given 5 minutes and I'll sort of get started. Okay, so those labs, as I said, so they were sort of phased out of the process. I think to put it in some context, this is government money we're talking about. Up to the 31st of July 2022, there were 35 million COVID tests performed by Australian labs at a cost to the government of $2.8 billion. So you can see for one test, it's quite a lot of money. So we want to actually make sure the pathology testing that we're all paying for is actually reliable and robust and accurate. So the milestone, the cervical screening program, I'm going to have to sort of go through this pretty fast, I'm afraid. This is a great success for Australia, first cervical screening program in the world, established in 1991. Obviously underpinned by accreditation. We found in the 2000s and the 2010s a significant number of labs who were failing the performance measures. If you're a cytologist, you know what I'm talking about. These labs failed. In discussion with the college, we organised for samples to be retested and women to be rescreened, and we found there was 30,000 odd tests that had to be retested because of these labs had failed. We found 20 or so women that were initially diagnosed as negative, were actually SIN3 high-grade lesions, and therefore entered a different care pathway. They would have been left for 3 years otherwise. So to me, that's a great success of accreditation. We found an issue, there were good standards to assess against, and we actually did something about it and improved the quality of life for those people. 2017, the testing changes, to HPV, which is thoughts are going to protect a third more people than the previous test. And the last line there, very exciting. I've got 2 daughters. Vaccination and testing will hopefully see the elimination of cervical cancer in Australia by 2035. That's an incredible success story for us. The next milestone is a personal one for me, because I was there in 1998 in Westmead newborn screening. The introduction of tandem S spectrometry to newborn screening. Anyone born in Australia from about mid-60s probably has been tested with a little finger prick, so you've all been exposed to pathology without even knowing it. The idea is obviously to pick up inborn errors of metabolism that would otherwise have been missed until symptoms show, and be able to treat those babies before it gets too bad. 300,000 tests a year, 99% of babies are tested here in Australia. So in 1986, tandem mass spectrometry was brought in, which has led now to newborn screening being able to pick up about 50 or 60 new diseases that they couldn't pick up prior to tandem mass spectrometry. So that to me is a huge success, and also a personal note because I was there at the time. The next one is ISO 15189 introduction. The first pathology standard obviously came on from 17025. It is, there's notes here, it's been adopted by 80 countries worldwide, 15189. That meeting there was in May in Berlin. There were 60 participants, both remotely and online, across 25 countries. So you can see the importance to the world to 15189 and the continuing interest. And just an example, go back one. Stuart Bryant there, it's Professor Stuart Bryant, anyone who knows him. He was recently retired chemical pathologist for Lifeblood. He was at the very first meeting in 1994, and I think he's missed 2 meetings in the whole time. So he represents the college. So the college and NATA have actually had a really strong influence on writing this standard. We talked about the TGA regulations, not very popular at the time, but it introduced legislation for in-house IVDs, world first. The UK and EU, the EU and the US are introducing IVD regulations somewhat 24 years later. It's had a huge impact on labs having to be accredited for every in-house IVD, but it brought in-house IVDs to the level of commercial IVDs, and there's been, I think we've seen a great improvement in IVDs, in-house IVDs across that time. So it wasn't very popular at the time, but so accreditation to ISO 15189, which gives it international recognition, and the MPAC IVD standard is very important. So I think well done to TGA, even though they copped a lot of bad press at the time. I think importantly, the accreditation process looks at clinical utility and clinical validity as well as our technical validity, and obviously we use pathologists to be able to determine that. So again, that close relationship. Whole genome sequencing introduced, first lab accredited for human genomics in 2016, and molecular biology, whole genome sequencing in 2019. Some of the sort of benefits we can see, we've spoken about personalised medicine a lot over the last couple of days. It's only going to get more and more, and whole genome sequencing really helps for that. Early disease detection, public health surveillance. When the next pandemic comes along, we can actually track where it's been and where it's going and which variant it is. So whole genome sequencing is a massive breakthrough for pathology. Just a bit about the changes to human pathology assessments in 2021. With the new MPAC documents that came out, we changed our process more on risk-based assessments and sort of supervision and the role of the designated person. So changed the focus of things. We still want to promote risk-based assessments. We're probably not quite there yet, so we're still training tech assessors into risk-based assessments, and perhaps design risk profiles for organisations based on what we find on assessments. So the Commission Quality and Safety in Healthcare put out a survey last year, which you may have participated in or may have heard of. This is sort of current to date last year. I think you'll see those results incredibly pleasing for everyone, because it talks about 89% agreed or strongly agreed in the value of accreditation in pathology, that accreditation adds value to patient care, 88% agreed or strongly agreed, and the peer review adds process as value to the accreditation process. Again, 83% agreed or strongly agreed with those statements. That's really positive for all of us, really, for all stakeholders in this. And again, for lead assessors and technical assessors out there, 83% agreed that our lead assessors have the skills needed to assess against the standards, and 83% thought technical assessors had the technical knowledge to assess. These graphs didn't look like this when I emailed it. They've gone a bit weird. So anyway. But not everything's roses. We still find labs with problems, a small number, and I think it's fair to say that labs have certainly improved over time. There's less follow-up assessments, less short reassessments and less suspensions, but they are still there. And this is from the last 6 months of last year. I'm not looking at you, Mel, because I know you're going to kick me off. So, the last 6 months of last year, not a great number of findings, but these are only high-risk findings. There's no medium or low-risk findings here. So still, I think, a significant number of findings against clinical governance and personnel and request test cycle. And I know many of you saw Emily's talk yesterday about the 5 or 10 highest findings. This is what we find all the time, those findings there. Another one that I wanted to show is sort of the risk to NATA, because this is the number of submissions that lab have to supply to us when we've done an assessment. It's pleasing to note that 20% had no findings, so all of our assessments in the 6 months to the December had no findings at all. That's great news. 40%, 41% only had 1 submission required, and 28% had 2 submissions. So those jobs are closed out within sort of 3 to 4 months. So that's about 90% of all jobs are closed out after only 2 submissions, which is very positive. But as I said, the downside is 10% actually went a lot longer than that. Some had 3, 4, 5, 6, 7 submissions going over sort of longer than 6 months. The concern for us is we know there's a problem. We've done an assessment, we found conditions, and we're waiting for you to close those conditions out. We're allowing you to give us multiple submissions. The risk is all ours because you're still accredited and you're still putting out results and NATA letterhead. So we're going to have to start doing something about those extended jobs after sort of 3 submissions or 2 submissions. We may start calling you and having a chat and getting the assessor involved and trying to close those issues out earlier, or if not, we may have to start thinking about suspensions or follow-up visits because we can't allow jobs to stay open when we know there's a problem for that long. Just into the future, I think we talked about point of care earlier. With workforce pressures and technology advancements, I think we're going to see more and more point of care. Hospital labs in the country may be closing down because there's no staff. Point of care machines going in. There's whole networks of sort of rural and remote point of care networks out there that we don't engage with at the moment. They see that it's just too hard at the moment to get accredited. So we're looking at new contemporary ways of doing assessments. We can do whole networks through remote assessments now, which we're working with a group to do that. But we need to change the regulations because at the moment we have to visit every site. So we're working with regulators to maybe come up with more contemporary point of care models. Digital pathology, telepathology, we all know about. Some labs are already accredited for digital, which leaves open for telepathology. AI, we're not going to talk about AI, I've done that. Precision medicine and global health impacts. But I think the bottom line, I think pathology is moving towards a digital, data-driven, integrated approach going forward, which we need to be ready for as NATA. So in summary, RCPA continues to deliver an accreditation process that is scientifically rigorous and globally recognised to provide confidence to all Australians. And the peer-to-peer process really supports that robustness and rigorousness of the process. But I think the last line is also, the last sentence is also relevant because it is an opportunity to provide information both ways, learning opportunities for the assessors and the labs, and really good open discussion. And promise my last slide, just take home this. We're all going to use pathology and we actually want those results to be right because 70% of all our healthcare diagnoses are made through pathology. 100% of our cancer diagnosis is through pathology. So we actually want those results to be right. Well, I do. So I think the take home is it's working, has worked for 40 years. We don't really need to change it very much. Thank you.